Okay, so continuing with the class. Next question. This condition is seen in vernal keratoconjunctivitis, simple allergic conjunctivitis, giant papillary conjunctivitis, and acute hemorrhagic conjunctivitis. So the answer will be vernal keratoconjunctivitis. Now, conjunctivitis, as we know, is an inflammation of the conjunctiva. Inflammation of the conjunctiva, which is characterized by redness associated with watery or mucopurulent discharge. Watery or mucopurulent discharge. So this is very characteristic, and when case studies comes, they often write this watery and mucopurulent discharge is present and with redness. So it gives you a very good clue that it is conjunctivitis. It can be conjunctivitis. Now, vernal keratoconjunctivitis, what is that? It is a bilateral interstitial self-limiting allergic inflammation of the conjunctiva, which is mostly seen in children, usually in summer months. It is caused due to hypersensitivity reaction to some exogenous allergen like grass pollen. And so basically it is a result of hypersensitivity reaction and this hypersensitivity occurs due to exogenous allergen like grass pollen. Exogenous allergen means allergen like grass pollen. So clinical features is characterized by marked burning and itching sensation. Marked burning and itching sensation usually tolerable. Lacrimation occurs, ropey discharge occurs, upper tarsal conjunctiva of the both eyes are involved. Lesions are characterized by cobblestone or pavement stone fashion. Typically, this cobblestone or pavement stone lesions are this typical picture of cobblestone appearance. You can see this is the conjunctiva. This is the palpebral conjunctiva, and this appearance is called cobblestone because it looks like cobblestone. This cobblestone. So typical picture of cobblestone lesion. Horner's Tranter spot can be found in vernal keratoconjunctivitis, VKC. Presence of discrete whitish red raised dots along the limbus is found. So another important lesion that is involved in VKC, vernal keratoconjunctivitis, is Tranter spot. And cobblestone appearance. Okay, so the main points are: this is allergic inflammation of the conjunctiva, result of hypersensitivity, occurs due to allergen like grass or pollen, characterized by burning and itching sensation. Burning and itching, very important, because this is the typical feature that the patient will tell. And for FMG, it will be it will come like this. The question will be framed like this: that there is burning and itching sensation, lacrimation, ropey discharge, upper tarsal conjunctiva of both the eyes are involved. So it's a bilateral condition. Another important thing is bilateral condition. Bilateral self-limiting condition. Automatically it can go, but it may be, before resolving, it may become severe also. That is why we do not keep we do not keep the patient untreated, obviously. We go for mast cell stabilizer and sodium chromoglycate. Simple allergic conjunctivitis is non-specific allergic rhinitis associated with hay fever or seasonal allergic conjunctivitis. This is simple allergic conjunctivitis. Okay. Next is giant papillary conjunctivitis. Giant papillary conjunctivitis. This is a conjunctivitis with the formation of large size papilla in upper tarsal conjunctiva due to localized allergy. So in GPC or giant papillary conjunctivitis, what happens? There will be formation of large size papilla, large size papilla, and the site will be upper tarsal conjunctiva, and there will be localized allergy. Especially occurs due to contact lens, nylon sutures, and prosthesis. Not due to grass pollen. Grass pollen, vernal keratoconjunctivitis. Grass pollen, VKC. And hay fever or seasonal or perennial allergic conjunctivitis. Perennial means throughout the year it may be present. That is simple allergic conjunctivitis. Hay fever. GPC. GPC occurs due to contact lens, nylon sutures, prosthesis. Especially contact lens. Nylon sutures also. Treatment is avoidance of the allergen and removal of the offending agent. That means if the patient uses contact lens, if the patient wears contact lens, he or she has to stop it, stop wearing it, stop using it. That is the weak treatment. And as the inflammation has already started, for the inflammation that is already present, for that we can give muscle stabilizer. But for long-term resolution, we need to advise the patient to remove the offending agent. This is about GPC. Acute hemorrhagic conjunctivitis. Acute hemorrhagic conjunctivitis. It is also called Apollo conjunctivitis caused by picorna virus. Picorna virus, enterovirus type 70. Now another summary of conjunctivitis. If it is bacterial conjunctivitis, there will be purulent and mucopurulent discharge. Watery discharge occurs in allergic conjunctivitis. Ropey discharge occurs in chlamydial conjunctivitis. Ropey discharge occurs in chlamydial conjunctivitis. Now in VKC, what happens? It starts with watery discharge. That means allergic conjunctivitis. It starts with watery discharge, but later on, if it is left untreated for many days to weeks, it may occur that there will be bacterial infection and mucopurulent discharge may start. Okay, or ropey discharge may start. If chlamydial infection occurs, ropey discharge may start. That's why we need to treat it. But BKC is overall is self-limiting. It can resolve without treatment, but that doesn't mean we need to left untreated, because it can complicate into bacterial or chlamydial infection as well. Okay, chlamydial trachomatis, A to C serotypes. A to C serotypes of chlamydial trachomatis causes ophthalmia neonatorum, VKC, paratrachoma, trachoma. And the answer will be trachoma. Trachoma, what is trachoma? It's a chronic keratoconjunctivitis again. Chronic keratoconjunctivitis primarily affecting the superficial epithelium of conjunctiva, cornea simultaneously. So primarily affecting superficial epithelium of conjunctiva and cornea. So which are the structures that are getting affected by this? Conjunctiva and cornea. It's one of the leading causes of preventable blindness in the world. Very important. Very important line. Leading causes of preventable blindness. Which one of the following is the leading causes of preventable blindness in the world? Trachoma. Next causative organism, Chlamydia trachomatis. The organism is epitheliotropic. That means it affects epithelium. Produces intracytoplasmic inclusion bodies called HP bodies. There are 11 identified serotypes: A, B, B, A type, C type, D serotype, E, F, G, A, J, K. Serotype A, B, A, and C are associated with blinding or hyperendemic trachoma, while D2K is associated with ophthalmia neonatorum. D2K, D from D2K, this ophthalmia neonatorum. But A, B, B, A, and C, A to B, A, B, C, this A to C or ABC type causes trachoma only. So very important point is, if chlamydial trachomatis infection occurs and if it is H, J or K serotype, then trachoma will not be there, will not be caused, will not occur. Rather, ophthalmia neonatorum will occur. It's a bilateral inflammation. It's a bilateral inflammation of the conjunctiva, bilateral inflammation of conjunctiva occurring in infant less than 30 days old. Before birth, it is very rare. Through infected amniotic fluid, it can occur in case of ruptured membrane. During birth also it can occur. Most common mode of infection from infected birth canal when the child is born with face presentation or with forceps delivery. After birth, infection occurs during the first bath or from infected clothes or hands. Causative agent, you see chemical conjunctivitis, silver nitrate or antibiotics used for prophylaxis, gonococcal infection and neonatal inclusion conjunctivitis caused by serotype D2K. D2K of chlamydial trachomatis is the commonest cause of ophthalmia neonatorum. Okay, so these are the causative agents of ophthalmia neonatorum. And ophthalmia neonatorum can occur before birth, during birth, after birth in these following ways. Okay, next question. Fat-like nodules on bilateral nasal side of conjunctiva is found in pterygium, pinguicula, chalazion, and hordeolum. And the answer will be pinguicula. What is pinguicula? It's a lattice degeneration near limbus. It is a bilateral condition, affects more commonly the nasal side or medial side, followed by involvement of the temporal side, and generally it is benign and needs no treatment. So this is the typical pinguicula. And you see lattice degeneration or fat-like nodules on bilateral nasal side of the conjunctiva. You see yellowish lesion you can see as if it is a fat-like lesions. Fat-like lesions are seen. Mostly it occurs in the nasal side. Mostly it occurs in the nasal side of the conjunctiva. And bilateral condition. Another important thing is bilateral condition. It can occur. It occurs both in both the eyes. In both the eyes. Totally benign, needs no treatment. Going to pterygium. It's a triangular invasion. Pterygium means it's a triangular invasion of something into something. So triangular pterygium of eye. That is why pterygium of eye. In this pterygium of eye, what happens? Triangular invasion of conjunctiva occurs into cornea. So you need to remember this: conjunctiva into cornea. Conjunctiva into cornea. And this is a triangular. You can see triangular invasion, triangular shaped, and conjunctiva from conjunctiva to cornea. Now it is very common in dry heat, sun exposure, abundant dust places. Iron deposition in the corneal epithelium occurs at the advancing head of the pterygium, is called Stocker line. Now at the head of the pterygium, what happens? Iron deposition can occur in corneal epithelium. In the corneal epithelium, in this side, iron deposition can occur. If it occurs in the head of the pterygium, and it is called Stocker line. No other symptom occurs due to Stocker line. No extra symptom occurs due to Stocker line. That's why asymptomatic. But you can visualize it if it occurs. Here it is not shown. You can visualize it if it occurs. Now the treatment is surgical excision of the pterygium. The commonest problem after excision is recurrence, which is reduced by post-operative use of mitomycin C, thiotepa, or by doing surgical excision with free conjunctival graft from the same other eye. That can be done. If it recur, then we will go for post-operative use of mitomycin C or thiotepa, or by doing surgical excision with free conjunctival graft with the same eye. From the same or other eye. So this is the treatment of pterygium. Next, we will talk about chalazion. Chalazion is chronic granulomatous inflammation. Chronic granulomatous inflammation of meibomian gland. No pain, painless condition. And incision and drainage. Chalazion. Hordeolum. External hordeolum or sty caused by staphylococcus infection of the Jay's gland. Treatment: antibiotics, topical antibiotics, hot fermentation. Hot fermentation. And if it is internal hordeolum, then acute staphylococcus infection of the meibomian gland. Extremely painful. This features pain or not This features is very important feature to distinguish during a question. If they tell that there is a inflammation of a gland, or show the picture, it's a painless condition, then you will obviously not think of hordeolum and all. And apart from that, you see here you can see the redness in the chalazion, in case of chalazion. But in case of hordeolum, you can easily see not only redness but also there is a little bit of pus accumulation. That's why whitish colored lesion, you can see whitish colored lesion, because due to the infection, acute staphylococcus infection occurred, and we do go for incision and drainage. Acute infection. Here also inflammation occurs, granulomatous inflammation, but there is no pain or no whitish colored pus accumulation. There is no pus accumulation. But in case of hordeolum, there may be pus accumulation. Treatment is IND, incision and drainage, for internal hordeolum, while for external hordeolum we go for topical antibiotics or hot fomentation. Applying hot compress. Okay, next question. Keratoconjunctivitis sicca is due to mucin deficiency, lipid deficiency, aqueous deficiency, impaired eyelid function. And the answer will be aqueous deficiency. Now, keratoconjunctivitis sicca. First of all, tear of the eye has 3 layers. Uppermost layer is lipid layer. Uppermost layer is lipid layer. Next layer is aqueous layer. And next layer, the innermost layer, is mucin layer. Now, what are the function of each of this layer? Now, lipid layer, this lipid layer is contributed or made by meibomian glands. Meibomian glands, and it lubricates and prevents evaporation. It lubricates and prevents evaporation of the tear, so that the eye doesn't become dry, to prevent dryness of the eye. This the function of tear is to prevent dryness of the eye and keep the eye hydrated. Now, each of this layer has different functions. Number one, lipid layer, it lubricates and prevents evaporation. So lubrication is also an important function of the tear. Lubrication of the conjunctiva, lubrication of the whole conjunctiva, and preventing evaporation or protection of the other layers. Protection from evaporation. Next is aqueous layer, contributed by lacrimal gland. Nourishes and protects the cornea. Next is mucin layer, and we know mucin is secreted by goblet cells. Goblet cells. It adheres the tears to the eye. So it is the very layer which actually be in contact, which actually is in contact with the eye, including conjunctiva and cornea. That is why its function is to adhere the tear, whole tear, all of the layers to the surface of the eye and keep the eye hydrated. While the topmost layer, lipid layer, it prevents evaporation and protects the tear. Okay, and the main layer you see contributed by lacrimal gland, aqueous layer, water layer, it nourishes and protects the cornea. It's the main layer, main functional layer. It provides the main function of the tear. Now, if this deficiency, then what happens? Keratoconjunctivitis sicca, dry eyes, and there will be inflammation of the cornea and conjunctiva as well. So it is a disease entity most commonly seen due to aqueous tear deficiency. It can be caused in Sjogren syndrome, hyposecretion of aqueous tear or aqueous layer of the tear, congenital alachremia, decreased secretion or lack of the secretion from the secretion from tear gland contribute to this condition. Now symptoms: foreign body sensation occurs. Itching also occurs, and the patient rubs the eye with the finger, and that's why there may be more redness. And photophobia occurs. Which test? Wetting of filter paper. It's called Skarma strip test. Can be done. Next is mucin layer deficiency can lead to xerophthalmia. If mucin layer deficiency occurs, then xerophthalmia may occur due to deficiency of mucin layer. Conjunctival scarring can be seen in Sjogren syndrome. Sjogren syndrome, chemical burns, and trachoma. Okay, so keratoconjunctivitis sicca, and again for IBQ, like dermatology, ophthalmology also experiences IBQs in the FMGE. So this may be the IBQ. So you need to see more pictures of keratoconjunctivitis sicca, although this is one of the typical picture of keratoconjunctivitis sicca. Next question. Early stage non-proliferative diabetic retinopathy. Early stage non-proliferative diabetic retinopathy is present as microaneurysm, dot and blot hemorrhage, hard exudate, and soft exudate. Answer will be microaneurysm. So diabetic retinopathy can be two types. One is non-proliferative. Another is proliferative. In non-proliferative, there will be microaneurysm, early manifestation. So the early manifestation is microaneurysm. Dot and blot hemorrhage also occurs in non-proliferative diabetic retinopathy. Hard exudate also occurs in non-proliferative diabetic retinopathy, as well as soft exudate also. And in proliferative, neovascularization of the disc occurs, neovascularization of anywhere else from the disc occurs, neovascularization of iris occurs, which is popularly called as rubeosis iridis. So basically, diabetic retinopathy is the constitutes the changes that are found in retina in diabetes, in a diabetic person in diabetes. That is diabetic retinopathy. Retinopathy due to diabetes. So in diabetes, there is pericyte necrosis. There is pericyte necrosis. Normal ratio is 1 pericyte to 1 endothelial cell, while in diabetic retinopathy, we can see 3 endothelial cells and 1 pericyte. Okay, so pericyte decreases, number of pericyte decreases. So that is more important portion is the vessel wall gets weakened and leakage occurs. Leakage occurs in diabetic retinopathy in the eye. In the eye. So non-proliferative diabetic retinopathy, proliferative. In non-proliferative, there will be aneurysm. That's why this leakage will, this weakening will cause aneurysm. What is aneurysm? Abnormal dilatation of the vessel. Abnormal dilatation of the vessel. Dilation of vascular dilation, okay, of the vessels in the eye. That is the early manifestation. And when this abnormal dilation or microaneurysm increases and stay for a longer time, they may get ruptured. This microaneurysm may get ruptured, and as it is microaneurysm, small abnormal, so the size of this dilatation or aneurysm is very small, very at the capillary level. At the capillary level, capillary for the eyes capillaries of the eyes get dilated abnormally. Microaneurysm occurs, that's why. And at the capillary level it occurs. So when it ruptures, they lead to dot and blot hemorrhage. Dot and blot hemorrhage. And in fact, before hemorrhage, there may be leakage, because when pericytes of the cells of the vessels become dilated, they becomes far away, they go far away to each other. They go far away to each other and leakage occurs. And due to this leakage, there can be hard exudates and soft exudates also. Similarly, edema occurs. Here also, this exudation occurs in the eye. So the treatment will be anti-VEGF class of drug should be given. Endothelial growth factors class of drugs should be given, anti-VEGF, which are used for the treatment of diabetic retinopathy, neovascularization, proliferative diabetic retinopathy, to prevent neovascularization. Because when they will get ruptured, there will be formation of new vessels, and those vessels are not matured enough, and they make those neovascularized vessels, new vessels will be more abnormal, will increase IOP, will increase IOP, leading to what? Leading to glaucoma in diabetes. That's why glaucoma occurs. In this class of drugs, what we can use? Ranibizumab, bevacizumab, and also picatinib. And treatment of choice is laser photocoagulation. Coagulation. and those are anti-VEGF drugs. Okay, next question. A hypertensive pregnant patient presented to you. Hypertensive patient, okay, with sudden painless loss of vision. So when a case will come, you need to extract the important thing. Hypertensive patient, pregnant patient, pregnant patient with sudden painless loss of vision, with sudden painless loss of vision. So these are the three main points. So what can be the possible cause? Tractional RD, retinal detachment, exudative retinal detachment, vitreous hemorrhage, regmatogenous retinal detachment, and the answer will be exudative. So retinal detachment is the separation of neurosensory retina from retinal pigmentary epithelium, RP, retinal pigmentary epithelium by subretinal fluid. It can be by subretinal fluid, it can be by other also. It should not be written like this, not by. This is a specific type of retinal detachment. The definition should be like this: retinal detachment is the separation of neurosensory retina from RP. If it is by subretinal fluid, if it is by subretinal fluid, then they are making it more specific. This is exudative retinal detachment. Exudative retinal detachment. Okay, so now RP retina neurosensory retina getting detached from RPE by subretinal fluid. It can detached due to subretinal fluid. Number two, mechanically. How mechanically we will discuss. And number three, mechanically and by break or hole in the break in retina. Now first, there are three types: exudative retinal detachment, tractional retinal detachment, and regmatogenous retinal detachment. Now we will go one by one. First, exudative retinal detachment is characterized by lesions of RPE. Is there detachment of the retina occurs without any break. If this is RPE, and the retina should be attached. If it gets separated, then got separated, but there is no break. There is no tear in the retina. So without any retinal break arising from, then why it got separated? Due to inflammatory disease of choroid, retinal tumors, retinal angiomatosis. If this is RPE, if this is retina neurosensory retina, or retina if there here is a tumor. So that is why it got detached. That is exudative retinal detachment. It is seen in posterior uveitis. Uveitis spelling is this. Uveitis, intraocular tumors, toxemia of pregnancy, central serous retinopathy affecting the macula. Macular involvement is symptomatic, may not be detected on direct ophthalmoscope. Foveal detachment results in permanent impairment of visual acuity. So what we can find in fundus examination? Initially, we should do fundus examination, fluorescein angiography, optical coherence, tomography, OCT, ultrasound. This is the initial test, imaging test that should be carried out. Now look at these 4 pictures. Number 1 is fundus examination. In fundus examination, we can see inferior exudative retinal detachment with shifting fluid. This is retinal detachment occurred from this. And this pattern is not continuing with this portion because this is fluid. Next, number B. This is fluorescent angiography. It demonstrates early diffuse hyperfluorescence and late hypofluorescence. First, there will be hyperfluorescence, and in later stage, there will be hypofluorescence. The late phase fluorescent angiography is shown. This is fluorescence angiography. Number C, optical coherence tomography or OCT is quite done nowadays. Quite done. It demonstrates exudative retinal detachment. This is RP. This is retina, and you see it is detached. And this here fluid collection occurred. This black color fluid. This is fluid. Reflection of fluid. With a scan, high internal reflectivity in the choroidal mass corresponding with the diagnosis of diffuse choroidal hemangiogram. Okay, sorry. No, C. Optical coherence tomography demonstrating exudative retinal detachment. Okay. Next is this B scan ultrasound, BUSG, B mode ultrasound. It confirms diffuse thickening of choroid and an exudative retinal detachment with A scan high internal reflectivity of the mass, choroidal mass, corresponding with the diagnosis of diffuse choroidal hemangioma. So in this case, this is a case and the picture belongs to the same patient. 4 pictures, A, B, C, D. 4 pictures belongs to the same patient. So what is the last diagnosis of this patient? Diffuse choroidal hemangioma. Diffuse choroidal hemangioma. Due to this, what was happening? There was a choroidal mass and the reflection came with high internal reflectivity. And it causes detachment of the retina, detachment of the neurosensoral retina, detachment of the retina from RPE, retinal pigment epithelium, and accumulation of exudative retina, exudative fluid. Okay, accumulation of fluid. So shifting fluid. Okay, so this is happening, and these are the four types of images. Very important. These are the four types of images. This is fundus exam, this is fluorescein angiography, this is OCT, and this is BUSG, ultrasonography. Okay. Okay. Next, tractional retinal detachment. Especially that means exudative retinal detachment occurs due to commonest cause malignant melanoma of the choroid, followed by pregnancy induced hypertension and malignant hypertension also end stage. And accumulation of subretinal fluid occurs between RPE and retina, but it occurs due to this detachment occurs due to detachment occurs due to mass or any other causes, underlying causes are there, like pregnancy induced hypertension, malignant hypertension, but no break occurs in this type of retinal detachment. Next is tractional. Tractional, by the name itself you can understand it's mechanical. Is mechanical traction. Progressive contraction occurs of the fibrovascular membranes over large areas of vitreoretinal adhesions, characterized adhesions. So what happens if there is retinopathy of pregnancy, if there is diabetes mellitus? Like in this, you see the retina is pulled away from the RPE by contracting fibrous tissue which has grown on the retinal surface. So what happens in diabetes mellitus? There can be dot and blot hemorrhage. That dot and blot hemorrhage we studied about. Dot and blot hemorrhage. Due to dot and blot hemorrhage, there will be neovascularization as well as fibrous tissue also. Contraction of the fibrous, deposition of fibrous tissue occurs in the retina, in the RPE. Now what happens? This fibrous tissue or deposited fibrous tissue this deposited fibrous tissue will later contracts contracts and the RPE get contracted, like is contracting with itself only and getting separated from the retina due to mechanical contraction. Due to mechanical contraction. There will be slowly pain. This is also painless condition, and there can be slowly there can be loss of vision, and only retinal detachment which is very slow onset. You see, in diabetes, what happens? There can be neovascularization and scar tissue. Then vitreous pulling on the neovascularization and scar tissue. Neovascularization and scar tissue is pulling. Vitreous pulling occurs, and when it pulls up, the scar tissue and new vessels, they this retina get lifted up. This retina get lifted up by the scar tissue or and new vessels from the RP. This is RP, and that is why simply it gets separated. Retina gets separated from RPE. This is called tractional retinal detachment. Regmatogenous. In regmatogenous, what happens? There will be retinal break produced by localized vitreous traction on the retina. Then fluid passes through the retinal break and causes retina to detach. So it started from break, retinal break. The formation of regmatogenous retinal detachment is shown in this picture. So detaching vitreous has torn the retina. Then vitreous continues to pull the retina surrounding the break, and fluid from the vitreous cavity passes through the break, detaching the retina from underlying RPE. So it is regmatogenous characterized by presence of retinal break opened by vitreoretinal traction, allowing accumulation of liquefied vitreous under neurosensory retina, separating it from RPE. So first there will be break, and break occurs due to vitreous pulling. Then retinal break occurs. Retinal break will occur. Then fluid means vitreous fluid. Okay, fluid means vitreous fluid will accumulate, will escape and accumulate under neurosensory retina, and RPE. Then retina separates from RPE. Retina and RPE separates. Okay, so the predisposing conditions are myopia, previous intraocular surgery like aphakia, pseudoaphakia, family history of retinal detachment, trauma, and inflammation. Next, vitreous hemorrhage. Vitreous hemorrhage is not a clinical feature of retinal detachment, but it is characterized by sudden painless loss of vision only. Sudden painless loss of vision. Floaters, no flashing of light. Causes are diabetic retinopathy, which is the most common cause, and young patient, most common causes in young patient, the most common cause is trauma or Yale's disease. In a nutshell, regmatogenous RD or retinal detachment, tear in the retina, vitreous fluid in subretinal space. This is how the regmatogenous type occurs. Then tractional types, contracting fibrous tissue, example diabetes mellitus, contracting fibrous tissue. Then exudative type, fluids in subretinal space, example tumors. Exudative types, fluid in subretinal space, example tumors like choroidal mass, choroidal malignant tumor between retina and RPE. And tractional, due to fibrous tissue, they contrast, they lift up this fibrous tissue can lift up the retina from RPE also without break. Then tractional retinal detachment. If break occurs, then it becomes regmatogenous retinal detachment, because if break occurs, there will be not only the break but also vitreous fluid will escape out. Vitreous fluid is escape out and accumulates between retina and RPE. So this will become regmatogenous then. Otherwise, if simply mechanically pulls out and separates from RPE, it becomes tractional retinal detachment. And exudative due to mass, due to presence of mass between retina and RPE, like choroidal mass. Okay, and predisposition diseases like diabetic retinopathy is one of the very important and almost in always present. And in case of exudative retinal detachment where mass is there, you can see intraocular tumors, posterior uveitis, central serous retinopathy. All these are associated conditions where exudative retinal detachment occurs. Next question, candle wax retinopathy is seen in sarcoidosis, amyloid, diabetic retinopathy, hypertensive retinopathy. And the answer will be sarcoidosis. Candle wax retinopathy. Sarcoidosis is a granulomatous disease of unknown etiology. Young adults, it occurs in young adults. Prevalent sign, ocular sign is unilateral condition, anterior granulomatous uveitis occurs. Common clinical ocular finding associated with sarcoid uveitis includes decreased or hazy vision, pain, photophobia, lacrimation, conjunctival injection, means redness, conjunctival redness, cells and flare in anterior chamber, granulomatous iritis with large mutton fat. Keratic precipitates scatter over the back surface of the corneal endothelium. Iritis spillover leading to the anterior vitritis. Then white exudative debris in the region of ora serrata with retinal vasculitis, that is candle wax drippings, and phlebitis called as venous sheathing, that is venous sheathing. And exudative debris in the region of the ora serrata, snowball or snowbank retinopathy. It is called as snowball or snowbank retinopathy. Next, amyloidosis. In amyloidosis, you can see adnexal pathology includes ptosis, keratoconjunctivitis, sicca, proptosis, ocular motility disturbance, palpable mass lesions, pupillary abnormalities. Pain accompanies orbital amyloidosis and its presence should prompt the examiner to consider alternative diagnosis. In amyloidosis, you see the conjunctiva, there will be ptosis, visible or palpable mass, recurrent subconjunctival hemorrhage. In anterior chamber, a scalloped configuration of the iris margin signify the amyloid deposition. So amyloid deposition can be seen as scalloped configuration, scalloped configuration of the iris. The name is also important because obviously like few of the questions will be as image based questions. There will be much more than IBQ. The normal question will be much more than IBQs. Okay, image based questions. So just the name has to be remembered. Name of the lesion, name of the surgery, name of the configuration, name of the imaging, science and all. Okay, so these are very important. So scalloped configuration of iris may signify amyloid deposition in the iris stroma or alternatively disruption of parasympathetic innervation of the iris sphincter. Anterior chamber involvement appears as whitish flocculent debris in the aqueous or on the lens capsule or on the iris surface. In lens, pseudopodia lentis punctured dots on the posterior capsule resembling amoeboid food processes are considered pathognomic of vitreoretinal amyloidosis in patients with familiar disease. In retina, we can see lacy, cobweb-like, sheet-like or stringy wheels of gray and yellowish white material in the vitreous. Symptoms in retina or vitreous can include Floaters, blurry vision, glare, sometimes asymptomatic cases also occurs. Diagnosis should be Congo red staining. Congo red staining demonstrate apple green by refringence when viewed through cross polarimetric filters. That remains the gold standard for establishing the diagnosis of amyloidosis. So amyloidosis diagnosis is Congo red staining demonstrating apple green by refringence when it is looked through crossed polarimetric filters, and the treatment should include surgical excision or debulking. That is the treatment of choice in amyloidosis. Okay, this is all about sarcoidosis and amyloidosis. Snow banking is typically found in pars planitis, endophthalmitis, Coats disease, and Yale's disease, and the answer will be pars planitis. Pars planitis, in other name, we call it intermediate uveitis. We call it intermediate uveitis. It denotes the inflammation of pars plana, part of the ciliary body. So inflammation of pars plana part of the ciliary body, that is intermediate uveitis, and most peripheral part of the retina. Mostly it is caused due to idiopathic reason affecting both the eyes. So bilateral condition. Okay, bilateral condition, and in 80% cases are bilateral, 80% bilateral of children and young adults. History of floaters, sign and symptoms. So clinical features includes history of floaters, quiet eye, slit lamp examination shows mild aqueous flare, fine capes at the back of cornea. Capes means keratic precipitates. Keratic corneal precipitates, actually. Precipitates of the back of the cornea. Fundus examination with indirect ophthalmoscopy reveals whitish exudates in the inferior quadrant present near the ora serrata. These typical exudates are referred to as snowball opacities. Typical exudates present as snowball opacities may coalesce to form gray-white plaque called snow banking. So, in intermediate uveitis, there will be inflammation of the ciliary body. Inflammation of the pars plana of the ciliary body of pars plana. Next, there will be whitish exudates in the inferior quadrant. Whitish exudates where? In inferior quadrant near ora serrata. Inferior quadrant near ora serrata. Next, this typical exudates refers to as snowball opacities. Snowball opacities. Then these small exudates called snowball opacities, they coalesce. They combine together. To form gray-white plaque called snow banking. Okay, so this is snow banking and pars planitis, found in pars planitis, and how it founds. It's written here, and the features also. History of floaters, very important. And slit lamp examination shows mild aqueous flare and fine capes, keratic precipitates. Now this is the table showing the anterior, intermediate, and posterior uveitis and its comparison. Very important, the treatment you see, intermediate uveitis, pars planitis, right? Pars planitis. So intermediate uveitis is pars planitis, and it is also written here also known as pars planitis. Idiopathic floaters are there, snowball, snow banking. Injection triamcinolone. Triamcinolone is the treatment of choice. And for anterior and posterior, anterior is iridocyclitis while posterior is chorioretinitis. Posterior uveitis occurs due to toxoplasmosis infections while other two are idiopathic. And in intermediate, floaters are there while sudden painless loss of vision occurs in both anterior and posterior. Keratic precipitates are found in anterior also found in inferior, also found. Okay, keratic precipitates plus, as well as snow banking, snowball and snow banking is the most important portion. And head-like in fog appearance, very important this terminology. Simply the question can come, head-like in fog appearance is seen in anterior, posterior, anterior uveitis, for intermediate uveitis, posterior uveitis, all of these. So no, head-like in fog appearance occurs in posterior uveitis and not in the other two, anterior and intermediate. For anterior uveitis, topical steroids and cycloplegics, while antimicrobials and systemic steroids are given in posterior. Topical steroids are given in the anterior while systemic steroids are given in posterior, and triamcinolone is given in intermediate, completely different. Need to be careful, and the table is very important for ophthalmology. Questions do come in FMG from this uveitis topic. Very important. Okay, next question. The patient is 51-year-old stay-at-home mother. Presented to emergency department with severe right brow, right cheek and right eye pain or pressure that started 2 to 3 hours prior. Okay. She noticed blurry vision from that eye and rainbow colored halos. Rainbow colored halos around light lights around the same time. Accompanying symptoms include acute nausea. She has vomited twice since feeling the eye pain. Since the eye pain, she has vomited twice and denies prior episodes. Denies flashes. There are no flashes. There is no evidence of floaters, diplopia. There is mild redness in the right eye. So summarizing the whole case. Okay, another thing is that slit lamp is given, slit lamp examination was done, and lids and lashes was normal. Conjunctiva was found to be injected, that means redness. Cornea hazy, anterior chamber shallow. Iris mildly dilated, lens nuclear sclerosis is found. Anterior vitreous body is clear. So, right eye pain plus mild redness. Blurry vision. Halos around light. Acute nausea and vomited twice since the pain. No episodes It has never occurred before. There is no flashes, there is no floaters, there is no diplopia. So what can be the condition? And the condition is primary open angle glaucoma. Primary open angle glaucoma. So glaucoma can be open angle, can be closed angle. Open angle glaucoma means it can be primary and it can be secondary. And again, closed angle glaucoma can be primary and secondary. In open angle glaucoma, the trabecular meshwork, the angle of the trabecular meshwork is open. Okay, so angle of the iris and cornea is large, and that's why trabecular meshwork is not completely blocked. That is the main difference between POAG, primary open angle glaucoma, and angle closure glaucoma. So trabecular network or meshwork, whatever, is compromised, but not blocked completely. While angle closure almost blocked, almost these trabecular meshwork or network almost get blocked due to the fact that iris and corneal angle becomes much smaller, and this trabecular meshwork get completely blocked and completely blocked. Okay, so what happened? This angle is called angle of anterior chamber, anterior chamber. So in open angle glaucoma, what happens? The pressure of the glaucoma is there but the angle of anterior chamber is still not fully closed, due to which the drainage to the canals work, and aqueous fluid cannot be drained at the required rate. That's why IEP occurs. So anterior chamber, angle of anterior chamber, it's called angle of anterior chamber, is not fully closed, and that is why aqueous fluid can drain. Drain, but at slow rate. But at slow rate. So you can see the signs like over 9 mmHg IOP is diagnostic. Cup to disc ratio is normal. Lamellar dot sign, very important, increased pallor, hemorrhages on the disc and disc margin. Visual field defects includes blurring of the blind spot, early field defect. So early field defect in open angle glaucoma is blurring of blind spot. Next, paracentral scotoma, Siddle sign, arcuate scotoma, ring or double arcuate scotoma, Raynaud's central nasal step, tubular vision, complete loss of vision also occurs. Ocular association may include high myopia, fish, endothelial dystrophy, retinitis pigmentosa, central CRVO, Primary retinal detachment and diagnosis may include more than 23 mmHg and discovering and field defect occurs. Management is topical treatment, topical PG, prostaglandin analog, topical beta blockers, alpha agonists, carbonic anhydrase inhibitors, cholinomimetics, and systemic for systemic treatment, carbonic anhydrase inhibitor and hyperosmotic agents. So these are the clinical features of PAG angle closure glaucoma. And the treatment will be laser iridotomy, immediate medical therapy to decrease the IOP like IV mannitol, should be given. Oral hyperosmotics, systemic carbonic anhydrase inhibitors, topical anti-glaucoma drugs, and pilocarpine. Now next is topic. These are all anti-glaucoma drugs. First is PGA, prostaglandin analogs, Travatan, Travoprost, Latanoprost, Bimatoprost. They increase, and this mechanism of action is important. These adverse reactions are all important. Ocular adverse reaction and systemic. Only dosing is not so much important. Next, beta blocker like timolol, levobinolol, carotolol, betaxolol, carbonic anhydrase inhibitor, dorzolamide, brinzolamide, but it may cause blurry vision hyperemia. Decreased aqueous production occurs. Decreased aqueous production occurs in beta blockers. So aqueous production, these drugs, they decrease the aqueous production in aqueous production only instead of increasing the drainage. So aqueous production can be decreased like this. And prostaglandin will increase the uveoscleral outflow, trabecular, not the trabecular one. Then alpha adrenergic agonists like brimonidine, apraclonidine decrease aqueous outflow, increase uveoscleral outflow. So decrease aqueous outflow and increase uveoscleral outflow. Then combination combos can be given, and the corresponding ocular adverse effect and systemic adverse effect you can see. So at least you should know what are the drugs involved, the name of the drugs, and the mechanism of actions and adverse reactions, especially systemic also ocular also, both the adverse reaction has to be is needed. Okay, is needed. So at least few of the adverse reaction like bradycardia, palpation, pulmonary bronchial contraction, asthma betaxolol. Okay, asthma betaxolol. So do not give to asthmatics, asthmatic individuals. Okay, beta blockers. Dry mouth, fatigue, coma in children is caused by alpha adrenergic agonist. So this sort of things you need to go through from this table. Okay, next question. Which one is seen after penetrating injury in ciliary body? Iridocyclitis, sympathetic ophthalmitis, endophthalmitis, corneal ulceration. And the answer will be sympathetic ophthalmitis. It's a bilateral granulomatous panuveitis. Bilateral granulomatous panuveitis, first of all. Occurring due to penetrating trauma to the ciliary body. So this is the first thing. This is the second thing, very important. The injured eye is called exciting eye. If two eyes are there, one eye is injured and another eye develops uveitis. Okay. So this eye, the injured eye, is called exciting eye. And the eye which is not injured but developed uveitis, that is called sympathizing eye. Sympathizing eye. It is follows after a penetrating wound, most common in children than in adults, doesn't occur when actual separation develops in the injured eye. Actually, due to immunity, these are due to injury, the inflammation starts in this eye. Uveal pigment acts as allergen and excites the plastic uveitis in the sound eye. Uveal pigment acts as allergen. So what happens when one eye is injured? One eye is injured. Uveal pigments leaks out or escapes. Act as allergen. Act as allergen. And this allergen stimulates autoimmunity or immune reactions, not autoimmunity, sorry, immune reactions. Stimulate this allergen stimulates immune reactions plus inflammation, obviously, in other eye or the sound eye or the normal eye, and it gives rise to sympathizing eye. Sympathizing eye. Okay, what is found? Dallen-Fuchs nodules are formed due to proliferation of this pigment epithelium of iris, ciliary body, and choroid associated with invasion of lymphocytes and epithelioid cells. So very important, sympathetic ophthalmitis, what happens? We can find out, we can see there can be Dallen-Fuchs nodules due to the proliferation of the pigment epithelium, and it is associated with invasion by lymphocyte. There will be invasion of lymphocyte and epithelioid cells. And do remember this name, Dallen-Fuchs nodules. Very important. Now we will revise the clinical picture of sympathetic ophthalmitis. First of all, it typically follows penetrating trauma. Next, there will be bilateral granulomatous panuveitis. Next, there will be granulomatous anterior uveitis and multifocal choroiditis. So in the prodromal stage, photophobia occurs, and in first sign of the presence of retrolentral flare or the presence of keratic precipitates, at the back of the cornea. The first sign may be the presence of retrolentral flare or the presence of keratic precipitates at the back of the cornea occurs. This is the first sign, and in the prodromal stage, photophobia occurs. Next, at fully developed stage, what happens? There will be signs and symptoms consisting with acute plastic iridocyclitis. Acute plastic iridocyclitis. Jalen-Fuchs nodules are characteristic of sympathetic ophthalmitis. Injured eye is exciting eye. Keratic precipitates may be present at the back of the cornea, while sympathizing eye or sound eye usually involve after 4 to 8 weeks of injury in the other eye. After 4 to 8 weeks, remember this also. It's not like that right after the injury. No. So in the exciting eye, in the injured eye, nothing happens. No, not like that. There will be KP, keratic precipitates at the back of the cornea. In exciting eye, there will be keratic precipitates in the exciting eye, and in sympathizing eye, it involves after 4 to 8 weeks. It develops uveitis. So in the exciting eye, there will be keratic precipitates, and in sympathizing eye, there will be uveitis. Okay. Treatment: early excision of the injured eye. Topical early excision means topical cycloplegics, IV or oral steroids are also used for the treatments. If it is severe, then it is early excision of the injured eye. Okay, next question. Poikilocytosis and anisocytosis are seen in megaloblastic anemia, iron deficiency anemia, nutritional deficiency anemia, thalassemia. Although this is not related from ophthalmology. Okay, then also poikilocytosis is the erythrocytes of irregular shape due to free radical damage, and anisocytosis erythrocytes of different size because of vitamin B deficiency, folic acid, and iron deficiency. So initially the anemia is normocytic normochromic. That means the size of RBC is normal, and chromicity, that means the amount of hemoglobin is normal. Subsequently it becomes hypochromic, microcytic. Subsequently it becomes smaller size, and it becomes again less amount of hemoglobin becomes small, reduces. So there is mild to moderate anisocytosis, variation in size, and poikilocytosis, variation in shape. So different shapes of RBC are found. That condition is called poikilocytosis. Irregular shaped erythrocytes. Because why it happens? Because of radical damage. And anisocytosis, erythrocytes of different sizes. This is the shape. This is size. Because of vitamin B deficiency, like vitamin B deficiency, folic acid, and iron deficiency. So both are found. So anisocytosis also found in nutritional deficiency, vitamin B12, B12 actually, megaloblastic anemia. So nutritional deficiency anemia, that is vitamin B12 megaloblastic anemia, but both are found in iron deficiency anemia. The long thin elliptocytes of iron deficiency are sometimes referred to as pencil cells. Target cells are uncommon, and anisochromasia is characteristic. Two features that can be useful in making the distinction from thalassemia traits. So target cell are uncommon and anisochromasia is characteristic. there is a fall in MCV, that means volume, and MCH when it is measured with sensitive technique, a fall in MCHC as well. And subsequently, so what happens? So size decreases and amount decreases. That means volume decreases, and volume means mean corpuscular volume decreases. Corpuscular which cell? RBC obviously. Their volume decreases and the amount of hemoglobin decreases. Amount of hemoglobin, that is mean corpuscular hemoglobin concentration, MCHC also decreases. Okay, so this is this happens in this both poikilocytosis and anisocytosis found in iron deficiency anemia. Like anisocytosis found in nutritional deficiency anemia also, but both of them found in iron deficiency anemia. And the pathological features should be like this. Anyway, it's not related to ophthalmology. We'll next go to the last topic, cataract, and we'll see cataract in details. Okay, so cataract. Basically, okay, cataract, basically it is a disease of lens. Disease of lens. And what disease? Characterized by the clouding of the lens. Clouding of lens. Now, especially this clouding of the lens, especially it occurs in at night. Especially at night. But it can also occur during the daytime if it is severe. If it is severe. And the cataract onset is slow onset. Slow onset disease whose onset is slow. And there can be different types of cataract. Different types of cataract. Slow onset occurs which is not congenital. Then only onset occurs. So anyway, we will go through the different types of cataract. First of all, on broad basis, we can see there is two types of cataracts. Two types of cataract. One is congenital or developmental. Another is acquired. So in congenital or developmental cataract, There are 4 types: cataracta centralis palverulenta, jonular cataract, sutural cataract, blue dot cataract. Now, cataracta centralis palverulenta, it is also known as embryonic nuclear cataract. Embryonic nuclear cataract. Bilateral small rounded opacity with powdery appearance lying in the center. Hereditary with dominant genetic trait. Hereditary with dominant genetic trait. Dominant genetic trait. Okay. And what happens? Bilateral small rounded opacities with powdery appearance lying in the center, in the embryonic nucleus, in the center of the lens, not in the peripheral lens. That is cataracta centralis. Next, jonular cataract, or we call it lamellar cataract. Most common type. Most common type of congenital or developmental cataract is lamellar or jonular cataract, accounting for 50% of the visually significant cases. Usually, jonular or lamellar cataract is bilateral. It's a bilateral condition. Opacity involves a zone of fetal nucleus around the embryonic nucleus with peripheral riders. Spokes of wheel appearance, very important, spokes of wheel appearance. So involves a zone of fetal nucleus around the embryonic nucleus with peripheral riders. Involves a zone of fetal nucleus around embryonic nucleus. So fetal nucleus in these type fetal nucleus has not developed, has not matured, and it is still present. Fetal nucleus is still present around the embryonic part. Actually, this is the embryonic part of nucleus. If this is lens starts dividing from center and it goes peripheral. This center portion is called embryonic nucleus. It's not that embryonic. This name came from because that part is found in the embryo obviously, but in adult lens also, lens of adult person also has this embryonic nucleus. An adult person also has this embryonic nucleus because it's a part of the lens, normal lens, adult lens. But in case of jonular cataract, what happens? The nucleus material during the fetal time do not mature and still it is present around the embryonic part of the nucleus. That is called jonular cataract. That leads to jonular cataract or lamellar cataract. And it gives a typical appearance of embryonic nucleus with fetal nucleus around the embryonic nucleus with peripheral riders, spokes of wheel appearance. So this this is fetal nucleus around the embryonic nucleus and spokes of wheel. This appearance, spokes of wheels. Spokes of wheels are these are all spokes. Spokes of wheels appearance occurs. This is lamellar cataract, may be genetic or due to vitamin D deficiency or maternal rubella. So why it occurs? It occurs due to maybe genetical or due to vitamin D deficiency or maternal rubella between 7 and 8 weeks of the gestation. Vitamin B deficiency or maternal rubella. So it occurs to the child, but new child, and if maternal rubella occurs between 7th and 8th week of gestation. Okay. Next, hypoparathyroidism during pregnancy also cause this type of cataract. So this is jonular cataract. Next, sutural cataract is usually static, bilateral, again bilateral condition. Punctate opacities occurs, very important. Punctate opacities. Scattered around Y-shaped sutures of different patterns. Next, anterior polar cataract. Okay, next blue dot cataract. This is called cataracta punctata cerulae. Cataracta punctata cerulae. Although it's not important so much, just for reference, blue dot cataract is also called cataracta punctata cerulae. Now it is a stationary rounded bluish punctate opacities are seen. Rounded bluish punctate, stationary, not moving, rounded bluish punctate opacity. So this is the nature. This is the nature of opacity. Stationary rounded bluish punctate involving adult nucleus or the deep cortex. Involving adult nucleus or deep cortex. Especially develops in second decade of life. Second decade of life. Does not involve vision. Does not involve, doesn't involve vision. That means interference with the vision or the quality of the vision is not so much affected. Visual quality of the vision is not so much affected. Okay, in blue dot cataract. Okay, next aqueous cataract. So the management management of congenital cataract. Management of congenital cataract. Number one, lens aspiration or lensectomy. Lens aspiration, it is also called lensectomy. That means the lens will be extracted out. It will be aspirated out with posterior capsulotomy and anterior vitrectomy plus posterior capsulotomy. That means the capsule of the lens will also be removed with posterior capsulotomy and anterior vitrectomy. But in normal cases of phacoemulsification, when we do phacoemulsification, this capsule is kept. Capsule is kept. Okay, it is not removed. But in case of congenital cataract, after the aspiration of the lens or lensectomy, the posterior capsule is removed through posterior capsulotomy. So this is the only treatment. Timing of the surgery, when the surgery should be done. If it is bilateral, then it is done 4 to 8 weeks. While in unilateral cases, urgent. If it is dense, then urgent. If it is partial, can be observed and treated non-surgically by part-time occlusion to prevent amblyopia. Okay. So if it is dense, then urgent surgery. If it is partial cataract, it can be observed and treated non-surgically. Okay, so this is about the management of congenital cataract. Next is aqueous cataract. Now, aqueous cataract includes senile cataract, which is the most common form of cataract. And under senile cataract, not under senile cataract. This is senile. First, aqueous cataract is senile cataract. Then metabolic cataract. In metabolic cataract, there is diabetic cataract, galactosemic cataract, sunflower cataract. Number 3 is complicated cataract, toxic cataract, and radiational cataract. Okay, it should come like this here. Metabolic cataract. So senile cataract is the most common form of cataract. It's the most common form of cataract of all cataract. Senile cataract is an age change. Obviously, in senile cataract, the age is the biggest factor. Factors affecting its onset and maturation may include heredity, exposure, so the factors includes heredity, exposure to UV radiation from sunlight, diet, and dehydrational crisis in childhood. Chronic dehydration, actually, chronic dehydration during childhood. Because when a person is not hydrated properly for longer time, it affects lens, and the lifespan of the lens becomes, shorter and shorter. Senile cataract. In senile cataract, what happens? Decreased levels of total proteins occurs. Decreased levels of total proteins. Amino acid and potassium associated increased concentration of sodium and marked hydration of the lens. Decreased levels of total proteins, amino acid, and potassium associated with increased concentration of sodium and potassium. Associated with increased concentration of sodium occurs. And marked hydration of lens occurs. It occurs. While nuclear cataract is accompanied by significant increase in water insoluble proteins, this is cortical senile cataract. This is about cortical senile cataract. And nuclear cataract, nuclear senile cataract occurs by a significant increase in water insoluble water insoluble proteins. Water insoluble proteins which give brown color to nucleus. Intensification of age-related nuclear sclerosis associated with dehydration. Nuclear sclerosis associated with dehydration. Are found in nuclear type. Two types, cortical and nuclear. In fully developed senile cataract, senile cataract, we find deficient or absent absence of glutathione, ascorbic acid, and riboflavin. Okay, so this is senile or age-related cataract. Questions comes like nuclear sclerosis and dehydration is found in, marked dehydration of lens and increase in sodium is found in, which type of, if they make it difficult, they will give the type of senile cataract also, or they will give senile cataract, this metabolic cataract, traditional cataract, like this. So each and every, the point is you need to learn each and every point, each and every facts. And if you can learn all these things, then it will be much easier for MCQ, much easier for solving the MCQ. Several MCQ can come from cataract, several MCQ. Okay, so next we will talk about, we will discuss about metabolic cataract. Metabolic cataract can be of diabetic cataract, galactosemic cataract, sunflower cataract. Diabetic cataract, true diabetic cataract. Diabetic cataract occurs in young adults. Acute onset, bilateral condition, very important, snowflake opacity. Snowflake opacities are found in diabetic cataract. Very, very important. Another thing is that in diabetes, diabetic retinopathy, you can see the glycolysis is hampered. And as glycolysis is hampered, energy is produced by sorbital pathway. Energy is produced by sorbital pathway. Produced by sorbital pathway. And that is why there will be accumulation of sorbital. Accumulates. Accumulation of sorbital. Very important. Fluctuating refractive error. Fluctuating refractive error is a feature of diabetic cataract. And also sorbital pathway, remember, this is a biochemical feature also. And snowflake opacity is very important. Next is galactosemic cataract. Galactosemic cataract is also called oil droplet cataract. Galactosemic cataract is also called oil droplet cataract. Galactosemic cataract is associated with inborn error of galactose metabolism. What happens? Inborn error of galactose metabolism. And due to the deficiency of galactose 1 phosphate uridyl transferase. Deficiency of galactose 1 phosphate uridyl transferase. Related disorders occurs due to the deficiency of galactokinase causing lamellar cataract. It is not related to that lamellar cataract. So accumulation of dalcitol is primarily responsible for development of galactosemic cataract. Dalcitol, accumulation of dalcitol. Next is sunflower cataract, very important, associated with inborn error of copper metabolism or Wilson's disease. Wilson's disease. In Wilson's disease, we can find this sunflower cataract. Okay, next is complicated cataract. Complicated cataract occurs secondary to uveitis, retinitis, long-standing retinal detachments, posterior subscapular cataracts, typically characterized by polychromatic luster and breadcrumb appearance. So complicated cataract occurs secondary to other diseases, like uveitis, like retinitis pigmentosa. Okay, pigmentosa. Then myopic chorioretinal degeneration, and then retinal detachment also. Toxic cataract. Toxic cataract can be corticosteroid induced due to drugs. Corticosteroid induced, myotics like ecothiopate or demacarium bromide due to drugs actually. Okay, due to drugs, toxic. Myotics. Myotics like myotics. Okay, like ecothiopate. Or demacarium bromide. Okay. Next, other causes can be chlorpromazine, amiodarone, gold, busulfan, used for treatment of myeloid leukemia. Busulfan. Okay. Due to drugs. And radiational cataract occurs due to heat or X-ray, gamma ray, neutrons. Okay, due to this. And most common type of radiational cataract is PSC or posterior subscapular cataract. Most common type of radiational cataract is is PSC. posterior subscapular cataract. Management of acute cataract or cataract in adults. ECC, that means extracapsular cataract extraction. Extracapsular cataract extraction. Phacoemulsification. Phacoemulsification. Aspiration of the nucleus or the lens will be done using emulsifiers using ultrasonic phaco probe. Okay. And IOL, intraocular lens. It can be anterior chamber IOL, it can be iris supported lenses or posterior chamber IOL. Again, there can be rigid IOL, there can be foldable IOL. Rigid IOLs are made up of PMMA. Question do come in FMG. Made up of rigid IOL. Foldable IOL is made up of silicone, acrylic or hydrogel. Silicone, not silicone, silicone, acrylic or hydrogel. So some of the FMG's question MCQs like most common type of congenital cataract. Most common type of congenital cataract. Lamellar cataract, cataracta centralis parvirulenta, coronary cataract, coralliform cataract. So answer will be lamellar cataract. The type of cataract seen in Wilson's disease. Sunflower cataract, snowflake cataract is seen in diabetes. Then posterior subscapular cataract. So some of the question in FMG, this most common type of congenital cataract, lamellar cataract, cataracta centralis, coronary cataract or coralliform cataract. So answer will be lamellar cataract. Next question like type of cataract seen in Wilson's disease, sunflower cataract, snowflake cataract, posterior subscapular cataract, coronary cataract. Snowflake is found in diabetes and answer will be type of cataract. Next question is type of cataract found in Wilson's disease. Sunflower, snowflake, PSC or posterior subscapular cataract. PSC is seen in radiational cataract and snowflake in diabetic. Snowflake opacities. Snowflake cataract found in diabetes. Very important questions. So, and Wilson's disease, sunflower cataract. Sunflower cataract. Cataract in newborn. Cataract in newborn is jonular cataract. Cataract in newborn is jonular, coronary, snowflake, cortical. Jonular will be the answer. Jonular cataract. Most common type of cataract. Most common type of cataract in adult. Is nuclear cataract, cortical cataract, Morganian cataract, none of the above. Answer will be cortical cataract. cortical cataract. Lens capsule is thinnest. Lens capsule is thinnest at central, lateral, superior, posterior. Superior pole of the lens, posterior pole of the lens. So answer will be posterior pole of the lens. The most common side effect of lens implant surgery. Most common side effects of lens implant surgery. Is vitreous hemorrhage, glaucoma, iridocyclitis, panophthalmitis? And the answer will be iridocyclitis. Okay, so this is about cataract and ophthalmology. Next day, we will start a new subject. So 2-day program was there. 2 days was scheduled for ophthalmology. Next day, on Tuesday, we'll start with another new subject.
Sure, no problem.
Okay. Okay, thank you.
Thank you so much.
Thank you. Thank you.
ఎక్కడున్నారండి?